Good afternoon, everyone. At first, I would like to thank Dr. Talwar for giving me this opportunity. So, I'll be talking how to read a normal macular OCT, what are the normal layers, what are the abnormalities that we see, and how to describe them. We know OCT is a tomogram due to varied degrees of reflectivity from the different retinal layers. So, when you see a OCT angiogram, how do you describe it? First of all, we do a qualitative analysis where we study the different layers, any alteration in their form, any anomalous structures, any difference in reflectivities, any hypo or hyperreflectivity, and then a quantitative analysis in which we see the thickness and the volume. So this is how you see a normal retinal macular OCT where you will see a central foveal depression. You get a very clear-cut retinal profile because the anterior and the posterior layers are very highly reflective. So you're able to get a very clear-cut scan. Now briefly I'll tell about all the layers of the retinal OCT. The innermost is the ILM, that is the internal limiting membrane, followed by a very highly reflective retinal nerve fiber layer. Then comes the ganglion cell layer. And then the alternating light and dark bands, the two lighter ones are the inner and outer plexiform layers, and the two darker ones are the nuclear layers, inner and outer nuclear layer. Then come these three very well-defined layers. The innermost, the thinner one, is the external limiting membrane, followed by this thick band. You see, this is the IS-OS junction, that is the junction of the inner and the outer segment of the photoreceptors. There are a lot of discs stacked very tightly here, that's why it's very highly reflective. And then finally the RPE complex, which is also very highly reflective. Now this is just a slide to show the correlation with the histological structure of retina. You will see that in the fovea, the inner retinal layers are missing. There's only the outer nuclear layer. And the outer plexiform layer is sloping towards the fovea. So this has a very important clinical significance because here it is called the Henle's layer, and whenever fluid collection is there, so then it assumes a petaloid pattern. That's how we see a petaloid pattern of edema. Now how to interpret the various colors that you see in the normal macular OCT? Some of the layers are very highly reflective and they appear as either red, white or yellow color. These include the internal limiting membrane, the nerve fiber layer, and the back layers, that is the RPE and the IS-OS junction. Some layers are medium reflectivity and they appear as green, like the two plexiform layers and this external limiting membrane. And finally, some structures which are very weakly reflective and they appear as blue or black, like vitreous, choroid, and the two nuclear layers. Now once you get an image, now how to proceed further? First of all, you look at the quality, then the area of the scan, and finally each layer individually then you see. In the quality, you have to look at overall clarity of the picture, whether there's any noise, any shadowing or any artifacts. You may get unclear pictures like this. Whenever you see this, you first try to adjust the focus, but in case if still you get this, then you have to look for any media opacity. Now in this case, you see shadowing because of some thick vitreous opacities, and here overall increased noise because of cataract. You may get artifacts like this. Now this is not a true gap, but actually due to a blink. And here you see these folds. These are not true retinal folds, but due to eye movement. Now how to differentiate them from actual pathology? First of all, correlate with the fundus picture. You see that area if there's any abnormality there, and then repeat the scan. So if it is an artifact, it will not come in the subsequent scan. It's very important to assess the foveal status. Now here you see this scan is not going through the fovea, so you get a false impression of edema here. But you have to assess because foveal status is important to manage your treatment. So ask the patient to focus on the fixation point. You look for the foveal depression and otherwise manually shift the scan on the screen to actually get the fovea. Now coming to the layers, to how to assess, it's easier if you distribute them into different zones. A pre-retinal zone, an epiretinal area, intraretinal region, and then the subretinal region. Now before I start the layers, you should know how to describe the alteration in the different layers. So these are the terms that we use to describe the changes. There's an irregularity, any interruption, any thickening, thinning, irregularity. So all these are the terms that we use to describe the changes in the retinal layers. Pre-retinal space, yes, it's a black space because it is very minimally reflective. But sometimes, yes, you may see some hyperreflectivity in the form, like here you see a membrane here, or you may say a diffuse kind of hyperreflectivity due to some vitreous opacity like hemorrhage. Now the epiretinal zone, normally the surface is very regular and smooth and hyperreflective, but in abnormality you may see different irregular surface which may depend on degree of the abnormality. You may see some anomalous structures also in the epiretinal zone, like here you see the membrane which is totally lifting up the surface. So you describe it as an elevated and irregular retinal surface. Or here you see there's an alteration of the foveal contour. This is because of NVE which was present here in this patient. Now coming to the intraretinal zone, here you see for changes in the reflectivity, any thickening, thinning and the integrity of the retinal layers. So coming first to hyporeflectivity. Any hyporeflectivity will appear as a dark black area. You may get a diffuse area like this or well circumscribed cystic spaces like this. Now usually these kind of dark areas or hyperreflectivity indicates fluid. So you may have diffuse fluid or in this manner. But all dark areas are not fluid. Now in this case this is not fluid. This is due to atrophy of the retinal cells. Hyperreflectivity you may see, like this you see intraretinal hyperreflectivity here. This may be due to CNV, choroidal neovascularization, or sometimes even hemorrhage. At times you may get very highly reflective, intensely reflective lesions like this, like in hard exudates. You see the shadowing behind them. There's a shadowing effect because they are so dense that they do not let the waves pass through. Then you have to note down the thickness of the retina. Any increase in thickness or any reduction in thickness, any thinning, so this you have to make a note of. And finally, you look at the integrity of the retinal layers. Is there any partial loss of retinal layer or a complete loss of retinal layer? So that's what you have to note. In the subretinal area, I'll just make a brief note of two important things. One is the change of reflectivity, which is usually the hyporeflectivity we see here. The important point to see here is, where is this? Because usually this is due to fluid. But at what level? Is it above the RPE? Here you see RPE is intact, so the fluid is anterior to this, so it's a subretinal fluid. But in case, here you see partly is subretinal, but you see the RPE itself is elevated. So the fluid is posterior to the RPD. Now coming to RPE itself, it's a very important layer because there are a lot of changes in this layer which are very crucial to a proper diagnosis of a disease. And so again, I'll re-emphasize that these are the terms that we frequently use to describe RPE especially. All these terms. So I'll just give a few examples fast. Here you see this is an undulated kind of an RPE. Then here there's an elevation of RPE. Here you see a disruption of the RPE. Thickening, thinning. Here you see this is normal RPE. Here you see a thinning of RPE. Fragmentation, so breaking of RPE here, and then an irregular RPE. So this is how you have to accurately describe the various changes in RPE. And then finally in the quantitative analysis where we take a retinal map which tells us the thickness and the volume of the retina. And one good thing is that here you can do a change analysis which tells us to change from the previous visits, whether it has increased or decreased, so telling us how is the disease progressing. So finally, for a good accurate OCT reading, you should know your anatomy very well, the features of the various retinal diseases, evaluate the gram very systematically, and correlate with the fundus features as well as with the history of the patient. Thank you.